presentation on THA from the anterior lateral approach. Our objectives for today, students will be able to define total hip arthroplasty and its purpose, explain indications for the anterior lateral approach, identify precautions and contraindications, outline the surgical procedure, and discuss rehabilitation phases and exercises.
All right, the THA surgery. THA surgery is the most common major surgery of the hip joint. The anterior lateral approach is preferred for patients that have an exaggerated hip flexion posture. So if they have like an anterior pelvic tilt, they're probably preferred for anterior lateral approach. The leading underlying pathologies that end up requiring THAs, always at the top, and then followed by RA, hip fractures, and osteonecrosis. During the THA, both the femoral head and acetabulum are replaced. There's two different kinds, as we talked about, conventional and resurfacing. And for the purposes of this presentation, we're going to be talking about conventional.
Alright, some of the indications for this surgery include severe hip pain with range of motion and weight-bearing activities specifically associated with rheumatoid arthritis and osteoarthritis. Then we have non-union fracture, hip instability and deformities, bone tumors, and poor conservative management after an initial surgery.
All right, precautions. You have medications, especially blood thinners, because they can be a big problem during surgery. Dental procedures, if they have a dental procedure scheduled, dental procedures may cause infection in the blood, which can cause incision and surgery to become infected. So you want to talk to them about that, and then not have them at the same time, preferably about 3 or 4 months apart. Some other precautions may be weight, hip range of motion, and home modification. Home modification, you just want to talk to them about it before the changes you have to make, especially the seating height and everything. Some of the post-surgical precautions include no hip extension, no external rotation, no crossing legs, limiting hip flexion above 90 degrees, and avoiding combined motions of flexion, abduction, and external rotation. And then I got a video that shows these precautions.
After your total hip replacement surgery with the anterior approach, your surgeon may give precautions for the first 6 weeks after your surgery. These precautions may be in place to minimize the risk of hip dislocation. The first precaution they may give you is to prevent hip extension. In lying, this is done by preventing yourself from bridging on the bed or lifting your hips away from the bed. The second precaution they may give you is taking your leg out to the side. When it comes to standing, you need to avoid bringing your surgical leg behind you and turning your toes away from your body. Instead, when turning, you should pick your feet up and do small steps on the spot.
Before surgery, we have joint infections, sepsis, bone loss, osteomyelitis, osteoporosis, paralysis of surrounding muscles that are around the hip joint, and neuropathic hip joint. Then after surgery, you want to avoid excessive internal and external rotation, high impact activities such as squatting, jumping, running, lunging, and then non-compliance with weight-bearing precautions. Alright, and then here is just the surgical procedure for the anterior lateral approach. So this approach is commonly used due to its stability benefits and lower risk of dislocation compared to the posterior approach that we just learned about. So this procedure begins with an incision made over the greater trochanter, positioned laterally to the TFL. The incision allows access to the hip joint while minimizing disruption to key stabilizing muscles. Next, the iliotibial band is carefully split to further expose the hip structures. Then the anterior 1/3 of both the gluteus medius and minimus muscles are detached from their insertion. In some cases, the surgeon may also have to detach the vastus lateralis to improve joint exposure. Then, to access the hip joint, the surgeon performs a capsulotomy, which is an incision to the joint capsule. The hip is then dislocated anteriorly to allow for adequate exposure of the femoral head and acetabulum. And unlike the posterior approach, the external rotators remain intact, which helps with post-operative stability. Then, once the joint is fully exposed, the damaged femoral head is removed and the acetabulum is reshaped to accommodate the prosthetic socket. The surgeon then inserts the prosthetic components, ensuring precise positioning for optimal joint function. This step is important for correcting the leg length discrepancies and optimizing the hip mechanics. Then, after everything is securely in place, the gluteus medius and minimus is reattached to the greater trochanter, and the IT band and the skin layers are closed, which completes the procedure. Then we just have 2 videos. It actually shows like an actual surgery happening. They're pretty lengthy, so y'all can watch them on your own time.
All right, for the rehab process, the goals and interventions for the conventional anterolateral THAs, or this is for anterolateral THAs, but it can also be used for resurfacing. Just keeping in mind, resurfacing patients tend to recover about a week or 2 quicker than conventional THA patients. For the max protection phase is going to be about the first 4 weeks. The goals are going to be scar tissue mobilization, very light weight bearing as tolerated. That's usually not going to be in the first 2 weeks, but 3 or 4. Ambulation with an assistive device, distal joint active range of motion, hip joint passive range of motion, and patient education on hip precautions. Some interventions for the maximum protection phase include quad sets, glute sets, heel slides, hip abduction and adduction while in supine, and hamstring stretches with a strap-in supine. Alright, goals for the moderate protection phase. The moderate protection phase is going to be about 4 to 6 weeks. It could be up to 8 weeks depending on how long they're requiring the use of an assistive device for ambulation. The goals are going to include improving endurance, start working on gait, strength training, focusing on abduction and extension, upper extremity conditioning to help with basic functional tasks that require upper body, and continuing patient education. Some interventions include mini squats, straight leg raises in supine and sideline, hook lying marches, and upper extremity exercises such as seated dips. Goals for the minimum protection phase, which is going to be about weeks 6 to 12, include advanced endurance training, exercising on unstable surfaces, gait and stair training without an assistive device, and patient education on safe return to function. Interventions for this phase include stationary bike for warm-up and endurance, stair training using the rails, small ranged lunges, 3-way hip on foam pad, and long distance gait training. Alright, these are just some pictures for y'all to look at. Alright, to conclude, THAs are the most common major surgical procedure for the hip, with the anterior lateral preferred for patients with exaggerated hip flexion posture. We went over the procedures for conventional THAs. We also talked about the indications for, the indications, precautions, and contraindications for THAs, focusing more on the hip precautions. And lastly, we went over some of the goals and interventions, keeping in mind that the ultimate goal is to get the patient back to prior level of function.
So what are some of the different precautions for the anterior lateral approach compared to the posterior lateral approach for THA?
Most of them are the same. The hip flexion, you can have more hip flexion in anterior lateral approach. They still say that you shouldn't, but doctors argue that it really doesn't matter up to a certain point or after a certain point. And then adduction with the anterior lateral approach, you can do adduction, unlike the posterior.
Why do you think osteoporosis is I don't know if it was a precaution or contraindication?
a contraindication. Osteoporosis is bone loss, so if there's no good bone formation, it's probably not a great idea to go in and mess something up in the surgery.
So why is the exaggerated hip flexion like an indication for the surgery?
So with the posterior, when you have that exaggerated hip flexion, you're putting more pressure on the back, like the posterior part of the hip joint. So you're leading yourself to more dislocations in that sense.